Our topic today is medical assistance and dying in Canada, and it's an honor to welcome Professor Jocelyn Downie, who is one of the foremost experts on end-of-life law and policy in Canada. Jocelyn is the James Palmer Chair in Public Policy and Law at Dalhousie University. She was a special advisor to the Canadian Senate Committee on Euthanasia and Assisted Suicide. She is a member of the Royal Society of Canada expert panel on end-of-life decision-making, the plaintiffs' legal team in Carter v. Canada, the Provincial-Territorial expert advisory group on physician-assisted dying, and the Council of Canadian Academies expert panel on medical assistance and dying. Jocelyn was named a member of the Order of Canada in recognition of her work advocating for high-quality end-of-life career. Congratulations on that. She's also a fellow of both the Royal Society of Canada and the Canadian Academy of Health Sciences, and the author of Dying Justice, a case for the decriminalization, euthanasia, and assisted suicide in Canada. Welcome, Jocelyn. Thank you for accepting our invitation. I know you have a very busy schedule, so it's a pleasure to have you here.
Thanks very much. I'm delighted to be here. I really appreciate the opportunity to come and speak with your community about medical assistance and dying. This is such an important time to be talking and thinking about this issue, in part because it's really important for us all to understand what our rights are, and we've had some recent changes to the law that impact on those rights. And also because we need all to be ready to engage in the public policy conversation that is imminently coming our way as Parliament considers some changes, potential future changes, and reflects on how the law has worked to date. So as you know, I'm going to be talking about MAiD in Canada, medical assistance and dying. I'll call it MAiD all the way throughout. I have to always put a date on any talk I give because the law on MAiD changes fairly regularly these days. And so this talk is up to date as of June 27th, 2021. So what I'm going to do this afternoon is talk about the current law, give you an overview of where we actually stand right now with respect to the law, the data that we have to date, the most recent data, and some words about what you can expect in the future and what you might look to engage in the future. Okay, so the current law. Well, the first question you need answered is what is MAiD? What is medical assistance in dying? In Canada, it's two things, and we are unusual in that way. It is the administering of a substance to a person at their request that causes their death. That is provider-administered MAiD, and in the past would have been called euthanasia. It is also the prescribing or providing of a substance to a person at their request so that they may self-administer the substance, and doing so cause their own death. So that is self-administered MAiD, sometimes known as assisted suicide. So we have the two forms. We have provider-administered and self-administered in Canada. Who can provide MAiD? Again, we're unusual here. Physicians, that's common in all permissive jurisdictions, but also nurse practitioners in Canada can provide MAiD. Who can access MAiD? Well, you have to be eligible for government-funded health services. This is in part to prevent people just coming to Canada in order to access MAiD. You must be at least 18 years of age, be capable of making decisions with respect to your health, have to have made a voluntary request for MAiD, so it can't be made as a result of any kind of external pressure or coercion. You have to have given informed consent to receive MAiD after having been informed of the means available to relieve their suffering, including palliative care. And I would note the including palliative care is actually in the legislation. They are so explicit to make sure that that happens. Also, in order to access MAiD, you have to have a grievous and irremediable medical condition. What does that mean? Well, there are three elements to that. You have to have a serious and incurable illness, disease, or disability, be in an advanced state of irreversible decline in capability, and the illness, disease, or disability, or the state of decline, has to cause enduring physical or psychological suffering that is intolerable to the person and cannot be relieved under conditions that they consider acceptable. So note that the assessment of suffering is subjective. It is for the individual to decide if their suffering is intolerable. Now, there's a little asterisk on the first bullet, serious and incurable illness, disease, or disability, because right now under the law and until March 2023, Mental illness is not considered to be an illness, disease, or disability. So if you have a mental illness as your sole underlying medical condition, you're ineligible for MAiD right now. But on March 17th, 2023, that exclusion will be automatically repealed. You may have heard people talk about a sunset clause. That's the clause in the most recent legislation that says this exclusion will be automatically repealed in 2 years' time. So it's excluded right now, but in 2 years will not be. So those are the eligibility criteria, who can do it and so on. There's a series of procedural safeguards as well. And there are 2 tracks now. We didn't used to have this, but the recent change in the law in March of this year has introduced 2 tracks. Track 1 is for people whose natural death has become reasonably foreseeable. And track 2 is for people whose natural death is not yet reasonably foreseeable. So the first question you probably are asking right away is, well, what does this mean? Natural death has become reasonably foreseeable, sometimes called NDRF or RFND. Those acronyms are referring to the same thing. It's really important to know that natural death has become reasonably foreseeable does not mean you have a 12-month prognosis or a 24-month prognosis, or indeed any specific prognosis. You don't have to be terminally ill at the end of life, anything like that. What it does mean is either sufficient temporal proximity, so a matter of years, not 20 years, but a matter of years it can be, and or a predictable trajectory toward death. And the best example of that is ALS, the amyotrophic lateral sclerosis, a degenerative neurological condition. It's one that Sue Rodriguez, who's a famous woman who was at the heart of the case named Rodriguez, where the first challenge to the prohibitions on assisted dying happened. She had ALS. A number of people who pursue it MAiD have ALS. And on the day of diagnosis with ALS, you have a predictable trajectory toward death. Now, you're not eligible for MAiD because you don't meet the other criteria that I just told you about. You don't yet have it. You're not yet in an advanced state of irreversible decline in capability. You're not yet experiencing enduring and intolerable suffering, but you are natural. You have met NDRF. So it's either sufficient temporal proximity or a predictable trajectory toward death. So that's the key deciding factor as to which track you're on. So now you understand what it takes to get onto each of these tracks. What are the procedural safeguards for these tracks? Well, there's a set that are for both tracks 1 and 2, and here they are. First of all, 2 medical or nurse practitioners have to be of the opinion that the person meets the eligibility criteria. Then the request has to be signed and dated before 1 independent witness. That is a change. The first legislation on this was 2, it's now only 1. The person has to give informed consent to receive MAiD after having been informed of the means that are available to relieve the suffering, including palliative care. Immediately before providing MAiD, the person has to be given an opportunity to withdraw their request, and the physician or nurse practitioner has to ensure that the person gives express consent to MAiD. So you have to have capacity at the time you request MAiD, and you also have to have decision-making capacity and give express consent immediately prior to the provision of MAiD. There are 2 exceptions called advanced consent and final consent waiver, and I'll come back to those. But generally the rule is you have to give express consent immediately prior to the provision of MAiD. So that's what both track 1 and track 2 have to meet. Track 2, which remember, these are people whose natural death is not yet reasonably foreseeable. They have to meet additional procedural safeguards. So you have to have a consultation with a clinician with expertise. So if neither the first or the second physician or nurse practitioner has expertise in the condition that's causing the person's suffering, the first or second practitioner has to consult with a physician or nurse practitioner with that expertise and share the results of that consultation with the other practitioner. It's very important to note that this person is not providing the assessment for MAiD, is not the provider of MAiD. They're just consulting on the condition causing the person's suffering. And that's only where neither the assessor nor the provider have expertise in the condition. The second point is the person has to have been informed of the means available to relieve suffering, including where appropriate, counseling services, mental health and disability support services, community services, and palliative care. So you note the bolded words are additional to what has to be provided to track 1 people. In addition, the person has to have been offered consultations. They don't have to accept them, but they have to be offered with relevant professionals who provide counseling services, mental health and disability support services, community services, and palliative care. So again, track 2, you have to be offered consultations with these people. Also, both of the physicians and nurse practitioners have to have discussed with the person the reasonable and available means to relieve the person's suffering and agree with the person that the person has given serious consideration to those means. This is not to say that they have to agree with the decision the person is making. They just have to agree the person has given serious consideration to the means available to alleviate the suffering. There is also a 90-day period of assessment, period of reflection. So there are 90 clear days between the day on which the first assessment begins and the day MAiD is provided, unless the assessments have all been completed. You have to have 2 assessments, remember, and both physicians and nurse practitioners are of the opinion that the loss of capacity is imminent, and if they are, it can be any shorter period the provider considers appropriate. So a person has had the assessments, they've been found to be eligible for MAiD. Normally you have to wait 90 clear days, but if loss of capacity is imminent, that can be shortened. If it's not imminent, you gotta wait the 90 days. All right, now I talked about the final express consent exceptions. Remember, the rule is immediately before providing MAiD, the person has to be given the opportunity to withdraw their request, and the physician or nurse practitioner has to ensure the person gives express consent to MAiD. There are 2 exceptions to this. The first is called the final consent waiver. This is known colloquially by people as the assessed and approved option or Audrey's amendment. And the reason it's called Audrey's amendment is there was a woman named Audrey Parker in Nova Scotia who had breast cancer and had spread to her brain. And she was assessed and approved. She was found to be eligible for MAiD. She wanted to try to live through the holiday season. She loved the holidays and she wanted to live through Christmas and New Year's, but she was at risk of losing capacity. And if she lost capacity under the old law, she wouldn't be able to access MAiD because of the express consent requirement. So she died on November 1st of that year instead of trying to make it through because she didn't want to lose the opportunity to have MAiD. This was a very powerful example of a failing in the old law, which was that because of the express consent requirement, people were either accessing MAiD earlier than they would otherwise want to, or they were actually reducing their meds in order to maintain their capacity so that they wouldn't lose the ability to give that express consent at the last moment and so lose their ability to have MAiD. So recognizing those problems, the government introduced this final consent waiver. It is important to note it is only for track 1 people, so only where natural death has become reasonably foreseeable. So here's what it is. If the person meets the eligibility criteria for MAiD, so the serious and incurable condition, enduring an intolerable suffering, advanced state of decline, incapability, and their natural death has become reasonably foreseeable, and they are at risk of losing capacity to consent to MAiD, they can make a written arrangement with their provider. And that arrangement says MAiD will be provided on a specified day. And then they consent in this written arrangement to the provision of MAiD if they lose capacity prior to that day. And they can actually have MAiD on or before that day. So if they lose capacity 2 weeks in and the date is a month out, they can actually have MAiD 2 weeks in. Now you can only do this, you can only provide MAiD under these circumstances if the person doesn't demonstrate resistance or refusal. But note, they specifically say in the law, involuntary words, sounds, gestures made in response to contact. So somebody just flinches when you touch them, for instance, that doesn't constitute refusal or resistance. So there now is a way that Audrey Parker, she would have been able to say at the beginning of November, I come to an agreement with her provider. We will have MAiD on January 8th. And she would know, she would have comfort that if she lost capacity before then, she would be able to have MAiD. Now, the second exception is called advance consent, and it is just for failed self-administration. It's available for both tracks 1 and track 2. What has to happen is the person has to meet the eligibility criteria for MAiD, and then they have a written arrangement that their provider will be present at the time the person self-administers. And then the clinician will administer the meds to cause the person's death if, after self-administering, the person loses capacity to consent, but doesn't die. Either doesn't die at all, doesn't appear to be going to die, or it takes too long. So this is to protect people from failed self-administration and to enable clinicians to provide an injection, provider-administered MAiD, after somebody has tried to self-administer if it fails. Okay, so that's the current law. That's where we are with that. Now let's take a look at the data that we have to date. And this is actually very recent data because Health Canada just reported to a committee in Parliament with data that they haven't yet published. So this is hot off the presses. So this is the data for 2020. So there were 7,595 cases of MAiD. This represents 2.5% of all deaths. So this is up from 2% in 2019. There's slightly more men than women who access MAiD. 94% of the people who access MAiD are older than 65. Cancer is the reason, it's the condition behind the request for MAiD in 69% of the MAiD cases. This is followed by cardiovascular conditions, respiratory conditions, and neurological conditions, much, much less frequently. And the most common aspects of suffering that are identified are the loss of the ability to engage in meaningful activities and the loss of the ability to perform activities of daily living. These are profoundly important in the experience of suffering by people who are requesting MAiD. A few more bits of data. 82.8% of people who receive MAiD have received palliative care or had it available to them. 78.8% of written requests did result in MAiD, but of the remaining 20%, a number, 12.7% of applicants died prior to receiving MAiD. We can't see the percent, were deemed ineligible, or 2.5% withdrew their request between the point of having been found to be eligible and when the clinician was about to provide it. Interestingly, there are now there were 1,345 providers involved in MAiD. Remember, they have to be assessors and providers. You need at least two in every case. 95% were physicians, 5% were nurse practitioners. 40% were involved in just a single case of MAiD, and 15% of these were involved in more than 10 cases. So we're getting an interesting distribution of providers. There are a couple of studies. We're starting to get good empirical data from the research community about MAiD that gets us more data than we have from the federal government through its monitoring system. And I just wanted to flag a few really important conclusions from two studies that came out of Ontario. The first is that there was no difference in access to palliative care for people who received MAiD versus those who didn't. And in fact, the rates of palliative care increased after MAiD became legal because they were looking at a window of time. And also really important, given the debates about slippery slopes and vulnerable individuals that we had through all of the parliamentary debates about the MAiD legislation, those who access MAiD are privileged as opposed to socially or economically vulnerable. So directly from the paper, patients with low socioeconomic status are less likely to receive medical assistance in dying. And that is consistent with the experience in all of the other permissive jurisdictions. We have decades of experience with that in the Netherlands and Belgium, and also in Oregon and Washington State, and many more states now. That is what is consistently coming through, is that despite the concerns that people who are socioeconomically vulnerable will be disproportionately represented in MAiD, in fact, they have less opportunity to access MAiD. Okay, so let's turn to reflect a bit on the future. What's coming at us? So first of all, we're going to have new data because there are going to be new regulations. The current regulations will be amended and they will take effect in a couple of years. And there will be analysis that will be possible and required under the new reporting requirements. And what's most important is that what they will be gathering information on is race or Indigenous identity and disability, with the permission of the individual making the request for MAiD. But with their permission, we will now have information about these characteristics of individuals requesting accessing MAiD, and that's very important for the analysis of how the system is working and where any problems in the system might be. Also, the government will, for the purposes of determining the presence of any inequality, including systemic inequality or disadvantage based on race, Indigenous identity, disability, or other characteristics in medical assistance in dying, will be gathering this information and making it available for, they'll be doing their own analysis and making it available for analysis by independent researchers. So this is going to give us a greater insight into who is accessing MAiD, who is not being given access to MAiD, and whether the law is working properly. So that is coming. We're also going to have an independent expert review of a specific issue, and that is MAiD for persons who have a mental illness. In this most recent legislation in March, the Parliament has established that there must be an independent expert body appointed to recommend protocols, guidance, and safeguards to apply to requests made for MAiD by persons who have a mental illness. Because remember, in 2023, this is coming in. So this group has to give a report which contains conclusions and recommendations. And it's always important when you're looking at what a panel has been asked to do by the government to make sure that they've actually been asked to make recommendations, because otherwise it's a much less meaningful report, I would suggest. It's harder to hold the government's feet to the fire about anything. But anyway, this report actually has to contain conclusions and recommendations, must be provided to the ministers no later than March 2022. And then the ministers have to cause the report to be tabled in the House and the Senate within 15 days on which the House is sitting after the day on which they receive the report. So this will likely be the spring of 2022. And remember, this is against the backdrop that the mental illness exclusion that we currently have will be automatically repealed in March 2023. So the idea is this expert group will make recommendations as to whether anything different has to be done with respect to this group of individuals who will become eligible in March of 2023. There is also parliamentary review going on. The law required that the criminal code provisions and their application must be reviewed, and this review must include but not be limited to the issue of mature minors. So remember, way back at the beginning of this talk, I mentioned that you have to be 18. And so mature minors are individuals who are under 18 who nevertheless have the decision-making capacity. They have the capacity to understand the nature and the consequences of the decision. They would normally be able to have the authority to make all kinds of healthcare decisions for themselves, including, for instance, refusing treatment, where the consequence of that refusal would be death. And so the question before the parliamentary committee is, should mature minors be allowed to have access to MAiD? Advance requests, this is about individuals who don't meet the final consent waiver requirements. So they aren't already eligible for MAiD. They don't meet all of the eligibility criteria. So it's earlier in their process that they should be able to make a request, so that, you know, in the day I get my diagnosis of dementia, I am able to make a request that says, when I'm stage 6 dementia, I want MAiD. That will be considered. Mental illness is also a part of the parliamentary committee, even though there is this independent expert panel as well. The committee will also be looking at the state of palliative care in Canada, and will be specifically looking at the protection of Canadians with disabilities in relation to MAiD. Now, this parliamentary review is a joint House and Senate committee. They started their work in April 2021. They were named. They actually started hearings just in June. They have had 2 sessions. They must submit their report no later than April 2022. This committee, though, will be dissolved if and when an election is called. So it has the potential to be derailed in a way that the independent panel does not. But if there's no election, they will carry on, they will do their work, they will issue a report, and it will be entered in Parliament no later than April of 2022. There will also be massive public debate And I think it will be about two main issues: advance requests beyond the final consent waiver. So a lot of people with dementia are very concerned about gaining access to MAiD, or people who fear they may get dementia. And there's enormous public support for advance requests. So I don't have to meet all the eligibility criteria for MAiD, but I can make an advance request for MAiD. That'll be being debated. And also the mental disorders as a sole underlying medical condition. The debate will be about what procedural safeguards should be in place once this is legal, because as I said, it'll be legal in March of 2023. So a couple of concrete examples. For instance, should you have to have a psychiatrist be one of either the assessor or the provider? Should you have to have tried all quote unquote reasonable treatments before you can access MAiD, or can you refuse things that the clinician think is reasonable to try, and you say, don't want to try it, and I want MAiD? Those are the kinds of things that are going to be debated. So I think these will be in the public domain very significantly over the coming months. I also think the future may hold some litigation. There is a real problem with faith-based institutions and some palliative care focused units, services, hospices, and so on, who refuse to allow MAiD assessments or provision within their walls. And this is forcing individuals to leave the institution that they are in. With a long-term care facility, for example, it would be in fact their home, in order to access assessments and provision of MAiD. This can be extraordinarily painful for people to be transferred. It also can simply be impossible. Some people are not able to be transferred out of the walls. And so this is putting in stark conflict the freedom of religion, freedom of conscience, and the right to life, liberty, and security of the person, which lies at the heart of our access to MAiD in Canada, and also freedom of conscience of people who want to have MAiD. It's also putting a very fine point on a constitutional law question, which is, do organizations have freedom of conscience, freedom of religion under the Charter? I personally don't think that they do. If they don't, then they won't have any kind of a defense to being compelled to allow MAiD to happen within their walls. If they do have that right, then it will become a balance. And I still think they'll lose in court, but it's a tougher road to hoe. At any rate, what's going to happen is you will have a faith-based institution that receives public funding be challenged on its position of compelling individuals to leave the institution in order to access a MAiD assessment or provision. I suspect it's going to take litigation to stop this practice. In some places it won't. For instance, in Nova Scotia, we were able to actually get the only hospital that was asserting that MAiD shouldn't happen there to drop that, in part because we were able to demonstrate that the hospital was owned by the government, Nova Scotia Health. And so they really were in no position to be allowing services to be determined by religious views of the former owners of the institution. So, some provinces don't have a problem with it. Newfoundland, Nova Scotia, for instance, don't. It's a huge problem in Ontario, Alberta, and BC. And so I think we're likely to see litigation in that regard. Okay, before I shift us back to or out of my screen sharing, I just did want to flag this website for you, eoll.law.dal.ca. And that's a website that I have had for a number of years now. The goal of it is to provide access to information about Canadian law and policy with respect to end of life. So it's broader than just MAiD, but it certainly includes MAiD. And what I try to do is put up explanations of what the law is with respect to various kinds of end-of-life care, and also post, the major reports, the major cases, make it a repository for information so that the public can be can have access to that more easily than you might otherwise, having to dig around to find things, or look to a series of journal articles and so on that may not be available, publicly available, with a subscription and so on. So that's there for you. Let me stop sharing here. And now we can open this up to questions and discussion. I did want to leave lots of time for you to be to engage, because it's easy for me to think what you might want or need to know, but it's better if you actually can say what you would like to talk about.
Thank you, Jocelyn. Just a reminder that you can raise your hand. And we have a question from Gary. Gary, can you unmute yourself, please? Okay.
Hi.
Should be good now.
Yeah, that's great. Thank you. Can you hear me okay?
Yes.
Excellent. Dr. Downie, it's such a pleasure to spend time with you and listen to your webinar today. I am a MAiD researcher at Lakehead University, and in a lot of my research, I've come across a lot of stigma in terms of the LGBTQ+ communities. And I was really interested in your section where you talked about the future and looking at issues of race and Indigenous identity and disability. But I'm really wondering your thoughts on cultural competency in terms of people, members of the LGBTQ+ communities who opt for MAiD. I'm hearing a lot in my research from people who not only are stigmatized for opting for MAiD sometimes, but are also, because of the healthcare professionals' inability to support the chosen family and so forth. And so I'm just wondering if you would speak to that, if at all possible, please, and wondering your thoughts moving forward, because I am very curious about your inclusivity of the future and what you think, where you think we might be headed.
Yeah, I mean, I think gathering that information about access and problems with access is critically important, because we can't solve the problems unless we see them. As you said and noted, it's not a part of what will be added to the data gathering associated with the federal monitoring system. One of the things I've been advocating for just recently, as they're doing the committee is holding its hearings, is to do much more research, to facilitate more research that digs deeper into the cases that are requests that didn't end up being opportunities for MAiD. And that's by modeling on other studies that have been done in other jurisdictions where it's permissive. Because I think we have to get at who's making requests and not getting access, not because they don't meet the clinical eligibility criteria, but for other reasons. And who's not even making requests because they either don't know about MAiD or they fear. I mean, if you're, what you're describing, the stigma, they may fear the stigma and therefore not even make the request. So we need to back up. It's not just requests that are declined, but it's requests that aren't even made, and figure out what's going on. So I'm delighted to hear about your research, and the MAiD research community is, as you all know, expanding, and those are the kinds of things we need to look into to make sure there aren't barriers that are associated, that are specific to LGBTQ+ and MAiD, as opposed to the general problems we have with healthcare being inadequate for the LGBTQ community because of stigma and discrimination.
A question in the chat box: is there any reason as to why vulnerable people do not have access to MAiD?
That's another critical piece of research that we need to do. The speculation that you tend to hear is that MAiD is available to those who are used to having control over their lives because they can push to get it, is one thing. So that if I wanted it and I'm encountering some kind of a clinician who seems opposed, I'm just gonna say, well, you're not getting in my way. I'm going to find another way to do this. But if you have been historically disadvantaged and disempowered, that's not available to you in the same way. So as the system develops, and as we don't in fact have more than enough providers, so you have access issues, I think it's the same way that people of privilege get access to better healthcare often as it is in relation to exercising the power and privilege that they have. So I think that's part of it. I think there may be an element of clinicians not wanting to raise it with people who they see as socioeconomically vulnerable for fear that they're going to get criticized, and people are going to suggest the only reason you're saying this is because this person has a disability or is poor, that kind of thing, because that has been a part of what we've seen. But that is addressed, I think, in part by changing the view of a lot of people who think they don't have a duty to inform. I think clinicians have a duty to inform everyone who could be eligible for MAiD that MAiD is now an option in Canada. Because that's the other thing, right? One basis for being vulnerable is literacy or language. And if you're an elderly immigrant woman with not a lot of English, do you even know that MAiD's available? And if you don't know to ask, can I have it? So then you're not going to get it, even if you might want it. So I get that's all speculation though, because we don't have the data we need yet. We're 5 years in, and people are trying to figure out how do you get access to the data that's going to enable us to analyze and figure out what's actually going on here.
Thank you, Jared. Over to you.
Hey, yeah, sorry, can you hear me?
Yep.
Yes.
Yeah, I was just curious, you said that they were going to make a report for the track 2 in, I think it was 2023. I was just curious if you have any kind of speculation on what might be in that report, like what they would determine for eligibility, things like that. If you're not comfortable answering that's fine. I was just curious.
No, that's fine. So there's 2 reports that'll be coming. One is the independent experts, and one is the parliamentary committee. So the experts will be making recommendations specifically on mental illness, and I suspect that what you'll see are recommendations around, what kind of involvement of psychiatrists do you have to have? How much treatment do you have to have tried? Because remember, if I have cancer, I don't have to do any chemotherapy and I can still have access to MAiD, or I can try 3 and there may be 2 others, but I can decline them. So what are the rules going to be with respect to what treatment you have to have tried? Those would be, some people want to suggest you have to wait 5 years. So there may be, I don't know what I have no inside information. They haven't even named the panel yet. But those are the kinds of things you'll see in that from that group. The parliamentary committee, what do I think they'll say? I'm hopeful. I guess I don't have a crystal ball. So I hope they will make recommendations about the government using its power of the purse to facilitate more research. And research like there's a regular every 5 years in the Netherlands, they do something called a death certificate study that gets really good, important data for us, and also just funding research. So I am hopeful they'll do that. One of the big things to watch is, will they recommend having advance requests where you're not yet eligible for MAiD? The public really, really want that. I don't know whether the government will do it. I mean, so much is going to hinge on the results of this inevitable election, because, if it doesn't look like it's going this way, but if, for instance, there were a conservative government, there would nothing like that would happen. In fact, if anything, they would restrict access. But if it's a liberal majority, they might well do the advance requests piece. They might well do mature minors, because one thing I would note on both of those is that every expert panel that has been tasked to actually make recommendations on these issues has recommended mature minors be allowed to access MAiD, and that advance requests be available for people before they meet the eligibility criterion, in particular the suffering criterion, right? It's really problematic in my mind that you have to have reached a state of enduring and intolerable suffering before you can ask for, you can do this final consent waiver. What they'll do, so hard to predict. And one further piece is governments don't like to open pieces of legislation like this, right? If you think about it, abortion was struck down decades ago, and governments tend to be very wary of attempting to relitigate, not relitigate, but reopen legislation on these issues. So there'll be some hesitancy, I don't doubt, from any government to actually reopen our MAiD legislation. On the other hand, there'll be real pressure to open it to do advance requests and mature minors. And I would note that if Parliament, if the House of Commons, the government doesn't introduce legislation on that, I guarantee you that legislation will be attempted through the Senate, because Senator Pamela Wallin is there. She's very determined to have advance requests. There was enormous support for it in the Senate. So I think it'll come from there, even if it doesn't come from the government.
Martin.
Hi, Jocelyn. Martin Frith here.
Hey.
Jocelyn, one of the things that has, concerns me in general around our health reporting in Canada, and in particular around MAiD, is the lack of transparency. So if I could draw, the parallel with Oregon, since, 1998, they publish a report on their, with the Ontario, or the Oregon Health Authority rather. And so that data, and it really is copious amounts of data, including whether people had private insurance, et cetera, the multiple deaths, the reason why people choose a MAiD death. And it just seems in Canada, we don't have any comparable data collection, at least none that I'm aware of. So could you comment on where we're at with that?
Yeah, so we do have the data gathering, some data gathering now, and it's posted on the government website. And what happened was we had a series of interim reports, and now they have started with what they call the annual reports, because it took them a couple of years to get the regulations done, which establish how the information is going to be gathered. There's a federal portal. And of course, this is Canada. We have federal, provincial, territorial, jurisdictional issues. And so they had to navigate who was going to collect the data, what data was going to be collected, and then what they were going to do with the data. So we have about 4 or 5 years worth of data, and it tells us age, reasons, where it's happening. So when I say reasons, both the clinical condition that underlies the request for MAiD, and also the nature of the suffering that the person has identified as what is enduring and intolerable suffering for them. So there's that data is available. It is being expanded because of the most recent legislative changes. So as I said, race and Indigenous identity and disability will now be gathered, as long as the person agrees to have that information included. Another step that I understand should happen this fall is that the data that is gathered federally will be made more available. I don't think it's available at all right now. So made available to researchers, and hopefully they will be able to be making connections with other databases, so that they'll be able to start to figure out, drill down into maybe things like socioeconomic conditions and so on the basis, if you can have postal codes and things like that, make you do some analytical magic. So that should open things up. The thing about Oregon and its data is health and the criminal law are state-based in the states. So Oregon, the government, controls all of the health databases and controls MAiD. So it's much easier for them to do the data work, the data collection and publication than it is in Canada, because MAiD is federal, except for in Quebec. MAiD is federal, it's under the criminal code. Even in Quebec, it's under the criminal code, but Quebec has additional legislation. So the criminal code is where MAiD sits, and that's federal. And then the provinces administer healthcare. And so getting those to work together is challenging. I'll give you an example. Last time around, one of the things that surfaced was medical certificates of death, because that would be how we can get some good information about what's going on and do research. Well, medical certificates of death are designed, controlled at a provincial level. So what the feds did was they gathered people together and they came up with voluntary guidelines, but they couldn't force those guidelines on everybody. They couldn't force harmonization. So what we got was this good set of voluntary guidelines, and then some provinces adopted it and some didn't, and we have variability. So that's one of the biggest reasons why we don't have quite what Oregon has. But we're getting better, and we have a lot. And so people can go to the government website and see the report. The latest report, the data I gave today, is from Abby Hoffman from Health Canada, reporting to the House and Senate Committee two weeks ago, I guess. So I don't have a written report. I got that out of her oral testimony, but that report should be available in a couple of weeks, I believe. So in every year we will get that kind of data. We just don't have data on everything we would like to have data on.
Okay, thanks very much.
Thanks, Martin. And here's a follow-up question. Have you been able, or are you able to access data from Dignitas?
From Dignitas? I don't know.
I believe that's the clinic in Switzerland.
Oh yeah. And I mean, there's information about Dignitas and that people have done some studies where they find out how many Canadians have gone over and so on. So, but it's all under the control of Dignitas. So yes, and I mean, that was pressure. That was part of the pressure on the government to respond to facilitate MAiD in Canada, is because people were going to Switzerland, and there was a recognition that it's awful to make people have to travel to Switzerland, because Switzerland does not require residency. So Switzerland allows self-administered MAiD, and you don't have to have residency. So people could go to Switzerland, but you have to have money to be able to go. And so it becomes something that's only available to the privileged, and you have to be well enough to fly, which means people were accessing assisted dying sooner than they wanted to, in order to ensure that they could have access. So that was a part of the argument for allowing MAiD in Canada, was the phenomena of people going to Switzerland. And it's certainly really a part of the debate in the UK, because it is easier to get to Switzerland, certainly cheaper to get to Switzerland from the UK. And so a lot of people are making that argument there, is why, well, you're making me fly to Switzerland for MAiD. So there are some studies out there about, I have seen some about how many Canadians went to Switzerland. I think you'll find those numbers are vanishingly small now, because of the difficulty and expense of getting there, and relative availability of MAiD in Canada.
Next question. Do we have access to a list of medical doctors and nurse practitioners in Ontario that support and help with MAiD?
There is not a public list. I think that would expose people to harassment and abuse, but there is a central navigating system. So go on to the Ontario, if you Google sort of Ontario and medical assistance in dying, you get to a navigator system. And I think they may be regional. Pretty sure they're regional. And what happens, so you can self-refer, you're not dependent on a clinician being willing to refer you to the program, and that you can contact the program, and the program has the list. So the program knows who is willing to provide I mean, that's not a total list because there will be people who haven't signed up with the program. My physician might just be willing to do MAiD for me. They don't have to work with the program, but you can contact the program and the program will put you in touch with assessors and providers. And that is the same across the country. We have in Nova Scotia, a central program. And so Nova Scotia MAiD program, call them, they know who's out there. They have their own system for putting them up so that people can say, oh, I can take that one's near me or whatever. And you can get access that way. But there's no public list that I know of. Some docs are very public about being providers, and then you can just look them up and call them. The other thing I would note is there is an organization called CAMAP, which is the Canadian Association of MAiD Assessors and Providers. And so that is a network. They don't publish a list, but they are a network of assessors and providers and navigators and interested people from across the country. So they are also able to help facilitate. And Dying with Dignity Canada too does work with individuals who call and say, can you help us get in touch?
Lane.
Yes, a friend whose family is suffering from one of these illnesses the member was offered what they called a suicide kit, and then somebody came to show them how it worked. How does self-administration work?
Who were they offered that by?
They didn't say. Apparently the person is my friend. The person is away with their sister, and there's so much crying and whatnot. When he tries to get an answer, he doesn't really get anything usable for him.
Okay, so it may be there were organizations that were showing people how to end their lives, to self-administer with helium, with different methods. This was outside of the law. So when you talk about a suicide kit, it makes me think that may be what's going on. So it's not actually a part of the official system. Self-administration under the system would be that you go through the same process as somebody who is having provider administered. You have to be assessed to ensure that you meet all the eligibility criteria. And so you're assessed by two clinicians who have to both agree, physicians and nurse practitioners who have to both agree that you are you meet all of those eligibility criteria. And then if your preference is for self-administration, which is a tiny number of people in Canada at the moment, it's very small, and I think it'll stay small, then you would get a prescription for the drug that you should take and instructions for how to do it. Most clinicians will say they want to be present when you take it, in part because of potential for complications and so on, and now to be able to do provider administered if it fails. So the notion of somebody being given a kit and told to go off and, good luck, sounds unofficial. And these days, I would say nobody needs to be doing this unofficially. I would want to be doing it through the system and with a MAiD assessor and provider who can help.
It might be that they just were given the drug or whatever and just decided it was to call it a suicide kit. Maybe,
yeah. There is a protocol that the CAMAP, that the Canadian Association MAiD Assessors and Providers put out on self-administered MAiD to try and help so that people would understand what are the drugs, what are the instructions, how should somebody take this, how do you figure out the dose, all those kinds of things. And that's available on the internet. So hard to say whether they may have gone through the official process and some people maybe didn't participate in all the conversations, so didn't really
that could be
know what's going on. But you would not normally be just sort of handed something and say, off you go now.
Okay, thank you. I'll find out he's away with the person this weekend, and I'll find out later what went on.
Sure, you can email me if you want.
Okay, thanks.
Okay, thank you. Next question is, I have seen many in the disability community concerned that they would be offered MAiD rather than get adequate access to proper care services instead. Structural medical ableism is a worry.
Yeah, it's certainly a concern that has been expressed frequently. I think it is misplaced in the sense that clinicians, MAiD assessors and providers have no interest in, they're not trying to get people to access MAiD. They are trying to respect the wishes of somebody who wants MAiD. So that's one key piece to focus on. The other thing is that, the argument was made that we shouldn't have access to MAiD unless and until everybody has access to palliative care. And there's a parallel to this argument. And Justice Smith in the Carter decision, which was the decision that struck down our prohibitions on assisted dying, reflected on that. And she said, the thing is, basically, you can't hold an individual hostage to the failings of the system. So you can't tell an individual, oh, you have to wait until palliative care is better. You just have to suffer through because the system isn't working as well as it should. What you do instead is, and I would advocate for this, is it's always parallel tracks. So you're saying the individual who says their life is a state of enduring and intolerable suffering to them and cannot be relieved by any means acceptable to them, they should have access to MAiD and not be paternalistic toward them and say, you don't understand your situation, or you have internalized ableism and therefore you're making a bad decision. It's to say we respect your decision and your capacity to make your decision, but to always be advocating for better mental health services and supports, disability services and supports, so that people are not seeking MAiD because they can't access these other services and supports. So I advocate for that approach. I think it's unfortunate that wasn't the approach taken during the last round of legislative debate about MAiD, because I think there really was an opportunity to focus on this concept of parallel tracks and push the government to make commitments around mental health services and supports, disability services and supports, and so on. At the moment, it's twinning it at the moment that they are legislating greater access than was allowed under the previous legislation, because it was the opportunity. That's when the pressure point is, and the other thing is the government was in fact not free to not make too many negatives in there. They had to make the change that they made, which was taking out reasonably foreseeable, which opens it up to persons with disabilities. Doesn't open it beyond Carter. Carter was not limited in the way that our legislation was, but they didn't have a choice about that. So focusing your argument on that, don't get rid of reasonably foreseeable, was, I think, was just actually a poor strategy and missed the opportunity to advance the arguments around supports and services. But I am very concerned about, yes, the structural medical ableism is a worry. I'm actually very concerned, though, about the paternalism that comes with saying, you don't know what you want. So if it's suggesting that there's ableism in the individual, ableism in the provider should in fact be irrelevant, because it is not for the provider to assess whether the person's suffering is enduring and intolerable. So there isn't space for ableism in the relationship between the MAiD assessors and providers, because even if the assessor and provider held ableist assumptions, their assumptions have no place. Their view of things has no place in the decision about access to MAiD.
Thank you. I have a closely related question to Kelly's question. Can you tell us a little bit more about the slippery slope arguments and counter arguments for cases of mental health? And I'm specifically thinking about, for example, poverty-induced depression. So what is the slippery slope argument in that case? And also, how would law distinguish or differentiate between different types of mental health conditions, right? So since it's such a wide range.
Yeah, okay, so many different things here. So one thing to state immediately is that there has not been a slippery slope on eligibility criteria in our law. So there hasn't been a legal slippery slope. People want to suggest we've gone from up here to allowing all of these things, persons with disabilities, persons with mental illness, and so on. But that's an inaccurate description of what has happened in the law, because the law was changed when Carter struck down the prohibition, and Carter was grievous and irremediable medical condition. So it didn't exclude these things. What happened was the first piece of legislation that came through narrowed Carter. And then we had another decision from the court saying, you can't narrow it in that way, that's unconstitutional. So the next piece of legislation appears broader because it's broader than C14. C7 is the second piece. It's broader, but it's not broader than Carter. So we have not had a slippery slope in that way. People then are also concerned, a different slippery slope argument is you go from voluntary to non-voluntary or involuntary euthanasia. We have no evidence of that at all. There's no reason to believe that we are sliding that way. So just like the other permissive jurisdictions with decades of experience, we have no evidence of either the empirical or legal slippery slope. But then the other question is more about mental health, and there are a whole host of conditions that are under that umbrella. There can be challenges associated with determining the cause of conditions and so on. I mean, I would absolutely agree that it is a massive umbrella. And one of the first things I said when I saw the draft legislation that had this exclusion for mental illness was, what do you think mental illness means? Because there is no accepted clinical definition. If we turn to something like the Diagnostics Manual, it's a manual for mental disorders, which is different than mental illness. And it includes all manner of things that don't relate to the concerns that people are expressing, why they want to have exclusions. So people talk about saying, you know, they suggest you don't, we can't tell if mental illness is actually irremediable or it's incurable. Well, dementia is absolutely irremediable, incurable, and it's in the DSM-5. It is a mental disorder. So clearly it's not all mental disorders. So then you have to, because they're not trying to exclude so then you ask and you push and you sort of say, what is it that you're trying to keep out? And it ends up being depression, schizophrenia, personality disorder. You know, they want to say, no, anorexia is anorexia, you can have it. Trying to figure out what is the feature or features that make you want to suggest that this should not be allowed here, that this is uniquely problematic. And you don't get a good answer to that. What I would say is that we're using mental illness as a proxy, I think, and it's a poor proxy. So if your worry is about, can we assess capacity? Maybe, you know, it's harder to assess capacity in a person with a mental illness. No, that's not true. What it is in some mental illnesses, it can be complex to assess capacity, but so too in physical disorders. So what you should do is not be saying special rules for mental illness. You should be saying we have to be really good at capacity assessments, and we have to be really careful where it is particularly complex to assess the capacity. Or if you have issues around incurability, because some of the arguments are mental illness is never incurable. Well, there's debate about that, obviously. And also it doesn't only apply to mental illness. So if you have, because one of the things people say is mental illness is actually not it's not a disease, it is a set of symptoms. And that's why you can't ever say it can be cured or not. It's because it's a set of symptoms, and either the symptoms go away or not, but that doesn't relate to something being cured. Well, that also applies in some physical disorders. So again, is the issue that it's syndromic, that it's a syndrome, as opposed to I can tell you it's that particular bacteria, or, you know, I can identify your cancer. So I think we have to stop thinking of mental illness as unique. I think that will help us to stop being, you know, it's discriminatory to suggest that people with mental illness have less capacity or need to be protected from themselves than people without mental illness. It also sort of runs counter to, I think, a lot of training that is going on in medical and nursing schools, which is to say this divide, this notion that there's mental and physical, actually doesn't map onto reality. So again, it's just say, let's look behind the label and say, what is it that's of concern to you? And then let's make sure that the clinicians are really competent to do the assessments that relate to what it is that's of concern to you. And I would flag for you here, the federal government is actually using its power of the purse here, and it's already got a group of people across the country. Stan Kuchar was the leader around this in the Senate, to develop training, recognizing the track 2 group, which are not just mental illness, but the track 2 group, have additional complexities and questions and so on. And as well, to develop training that improves cultural competency, for instance, and cultural safety, which is hugely important. So that's what I would say there. And then on the poverty-induced depression, I think one of the things that's important in track 2 is to recognize that they are requiring the clinicians to dig and to figure out what is going on, and to ensure that the person has been offered possible alternatives to MAiD to address their situation. They have to do more than they historically did with under the old legislation. And in part, I think that's a reflection of a concern that some of the conditions will be either caused by or related to, or perhaps resolvable through, or the suffering associated with them reduced by non-clinical interventions, other kinds of supports and services. And that is a part of the track 2 assessment. That was a long-winded answer.
Yeah, thank you so much for that. Yeah, Elvin. Go ahead, unmute yourself. We cannot hear you. Can you please unmute yourself?
So while Alvin is getting unmuted, I had a couple of questions, Jocelyn. It's Martin Frith, and these two are related to, probably more related to healthcare practitioners. And, you know, I was wondering if you would comment. It seems that, you know, hospice palliative care as a subspecialty and palliative care as a subspecialty of medicine is, you know, relatively new, but it seems like the end-of-life folks in hospice palliative care have been really reluctant to embrace medical assistance in dying. And I was wondering, from your research and practice, how do you understand that?
I understand that as an evolving phenomenon. And by that, I mean, there are a number of people in hospice and palliative care who support MAiD. There are MAiD assessors and providers who are palliative care docs and nurse practitioners. So there's a split in the field. Some people feel that MAiD is a part of the toolbox available to a palliative care doc. Some people feel that they're complementary. They're not the same, but they're absolutely complementary. They can coexist. Some people feel they are antithetical, and they think that MAiD has no place in a hospice or a palliative care unit, and palliative care docs and nurses should have nothing to do with it. I think there's a battle going on in the field about that. It's I've watched it over the past years. I would say what's been truly remarkable is how many people in palliative care and hospice have come to see MAiD as being a part or complementary to palliative care. They fully support it being offered, available in hospice and in palliative care, whether they themselves do it or not. A huge number. I think there's a generational thing going on. I think a lot of the people who went into palliative care early on were quite religious. And so the religion, in a sense, was driving their opposition to MAiD, but it was experienced as being their concept of palliative care. But that's because their concept of palliative care had embedded some religion, basically. And what you see now is palliative care is the people going into palliative care now aren't coming to it that way or from that perspective. And so they are just like, absolutely, it fits. Why would it not fit? It's a method of alleviating suffering and honoring, respecting the person's autonomy. So my bet is that in optimistically 10 years, maybe more realistically 20 years, this is going to be a non-issue, that this tension between MAiD and palliative care will be gone. I mean, 2 years ago, the president of the Canadian Medical Association was a palliative care doc who does MAiD. The hospice here in Halifax, it allows MAiD. You can't go in solely for the purpose of MAiD, but it allows MAiD. Palliative care units allow MAiD. We've got palliative care docs here in Halifax who do MAiD. So I think what has to happen is people have respectful conversations. People have to say it's really important that if you're not comfortable with MAiD, you do not have to provide it. You have a duty to transfer care. You cannot get in the way of it, but you do not have to provide it. And be respectful of that, particularly in the context of palliative care, because it's probably a higher percentage who are opposed. But you know, that's something I'm seeing change dramatically.
Okay, well, thank you. I appreciate your optimism. I mean, I was thinking, the Canadian Hospice Palliative Care Association had that official position, that we neither prolong nor hasten the dying process,
Yep.
and so it's interesting that you see it. There's this split, and the times are changing. So
They do not speak for all palliative care, hospice palliative care people
anymore.
No, and there are some very loud palliative care docs who are opposed to MAiD, who you see at all the committee hearings.
Mm-hmm.
They speak for a part of the palliative care field, but definitely not all of it. And I don't know the numbers. I haven't seen a recent study, but I've actually seen a statement. There's a statement out of Australia, the palliative care community in Australia, which says, they can coexist. And everybody has to respect each other.
Mm-hmm.
Yeah. So, reason for optimism.
Okay, I'll take it.
Yeah.
And then the second question that I had was kind of related, and you touched on it earlier. And I think that probably what's happening is that there's been an immense amount of training for docs and healthcare practitioners around MAiD and end-of-life care. So the question, though, specifically is, it still seems that depending on the facility, the offering of MAiD is spotty, depending on where you're at in the country, depending on the institution, for example. So are there guidelines, or dare I say penalties, for practitioners that, don't provide options that really are part of informed decision-making and informed consent?
Yeah, so this becomes a matter for the colleges, the regulatory bodies of physicians and nurses. And so, for instance, in Ontario, the College of Physicians and Surgeons has a very strong position that clinicians have a duty to refer. So if you are a conscientious objector, you have a duty to refer. And that got challenged in court, and trial decision, Court of Appeal decision, very strong decision. The decisions are posted on that EOL website. Very strong decision saying patients' rights trump here, folks. And patients are vulnerable, and they're vulnerable to not having access to MAiD. They saw that. They saw that clinicians and nurse practitioners if they operate as barriers to access, that is rendering patients incredibly vulnerable. And so it's a terrific decision. I highly recommend having a look at it. So they upheld the college position that there's a duty to refer. Across the rest of the country, it's either expressed as duty refer or duty of effective transfer of care. So you do have that. So a clinician has that duty. If they won't meet that duty, they can be reported to the college and the college can discipline them. Slightly different issue is the duty to inform. I think it's very clear that they have a duty to inform. At any point they're getting consent to anything, which includes a plan of treatment, which includes non-treatment. At any point they're having that kind of conversation with the person. If the person might be eligible for MAiD, then well-established law with respect to informed consent applies. And MAiD is an option. It's one of the alternatives. And so they have an obligation to disclose that to the patient. Again, the remedy for that is you go to the college. And part of the problem is, of course, if somebody doesn't meet their duty to inform, how does somebody know to go to the college, right? That's going to come up if a family member then gets involved and finds out this wasn't raised with the person and then they suffered and so on. So it's almost in the remedy that there's the problem as opposed to the rule, because the rule is there, but there are a lot of people who don't think that they have that duty. And so a next wave of education and training, I think, is going to be about that duty. And I think the colleges have an obligation to do that informing, is to make it clear. Like in Nova Scotia, it's clear you have to follow the informed consent policy, and the informed consent policy says you have to tell somebody about all the options. So it's there, but people are scared. They sort of say, oh, I don't want to, if I raise it, people will think I'm trying to, I've given up hope and I'm trying to tell them they should have it and so on. Well, those same arguments used to be made about palliative care. Oh, I can't raise palliative care because they'll think I've given up on them and so on. And that's just not true. It's how you do it. Of course, you can cause enormous harm if you do it badly, but you don't do it badly. And we don't make our rules based on the idea that somebody's going to do it badly. So people have to learn how to do it. How do you have that conversation? How do you inform somebody about MAiD? Just as you have to teach docs and nurse practitioners, how do you inform somebody about palliative care? And part of why we actually don't do palliative care as well as we should is because we don't raise it with people early enough. It's not a part of our care planning early enough and for enough conditions. We tend to think of it as for cancer and cancer only, but it's very beneficial for many, many conditions. And so, we have to train people to raise it early and not make the person think you've given up on me. That's not what palliative care means. So I think MAiD is similar. And I think we have to push the colleges to be clearer with their members about the duty to inform. Because I think partly why some people aren't getting access is because they don't know it's legal. I live and breathe this. So of course I know it's legal, and everybody, all my friends and family know it's legal. But there's a lot of people in Canada who don't know that MAiD is now legal. And we need to do several, we have to let people know so that they can ask for it. And we have to do better about making sure that institutions are not blocking them and that clinicians are not blocking them, because sadly, that's also what happens is, a person can ask about MAiD and then clinician says, oh no, you have to be terminally ill. I mean, I've seen that happen. You have to be terminally ill to have MAiD. It's like, no, you don't. That's not our law. So we want to inform the public so that they can assert their own rights or the rights of their loved ones.
Right. And it's certainly, you know, much harder to advocate for yourself when you're in the system and going, especially at end of life.
Absolutely. Absolutely. So we also want, you know, institutions to be proactive in educating their staff so that patients have advocates.
Mm-hmm. Wow. I love your passion. Thank you.
Thank you, Martin. And thank you so much, Jocelyn, for this amazing presentation and the rich Q&A. It's a real pleasure and honor having you here. Thank you for your time again. And thanks to our listeners for your questions and for being here as well. And finally, in closing, I'd like to mention that we are supported by memberships and donations. So if you would like to become a member or contribute to our educational programs, you can do so on our website, www.humanistcanada.ca. Thank you so much again, and have a lovely evening.
Thanks, everyone.
Thanks, Jocelyn.
Thanks,
Bye.
Jocelyn. Bye now.